In this section, we'll describe clinical research methodologies. In general, there are two broad categories of biomedical research. There are descriptive studies, and these studies simply describe a phenomenon without attempting to ascertain its cause or relationship to any other factor. In contrast, experimental studies attempt to establish a causal relationship by a specific intervention by manipulating one group and observing what happens relative to the other. Descriptive studies. In medicine, descriptive studies try to determine the causes and risk factors for diseases by drawing connections between behaviors or exposures and diseases through observation alone. For example, an observational study could ask, is someone who smokes more or less likely to develop chronic obstructive pulmonary disease? There are several types of descriptive studies. For example, a case report. A case report is the most simple form of descriptive study. Here we have an observation made in a single patient. Case series are essentially a series of individual case reports compiled into a single report. So here we have an observation that ties together a group of patients. Further along the continuum would be a cross-sectional study. Here we have an observation of the prevalence of a disease within a defined population. There are two major types of descriptive studies. We have case control studies. These are retrospective studies in which causality is determined. For example, this approach looks at individuals who currently do or do not have a disease and looks into the past for a risk factor or risk factors or exposures which might put them at risk. In contrast, a cohort study is a prospective study in which risk factors are followed, used to determine incidence and causality. Here we follow a group of patients with or without a potential risk factor into the future and observe whether or not they develop a disease. The basic dividing line between case control and cohort studies is the direction of observation. In case control studies, we're looking backwards in time. We identify a group of patients who have a particular problem or particular disease, and we look back in time to determine what risk factors or exposures may have made it more likely that they developed this disease. In a cohort study, we identify a priori groups that we want to study, and we follow them forward in time, and we assess whether or not the predefined risk factors make them more or less likely to develop a disease or some other problem. Case control studies. Case control studies are the prototypical retrospective correlational studies. So in a case control study, you compare a group of people with a disease, these are our cases, and a group of people without the disease, these are controls. It then determines the degree to which each group was exposed to a particular risk factor. The main advantage of a case control study is that one can study rare diseases this way. If one studied a rare disease using a cohort-based study, the likelihood of development of the disease is so low that one will have very little statistical power to make any conclusions in that kind of study. In a case control study, one can collect all the cases that one can find of a particular disease process, find control subjects that match those case subjects that have all the same characteristics of those case subjects, and look backwards in time for both groups to see which exposures differ between those two groups. The output of a case control study is the odds ratio. The odds ratio is calculated as the probability of the risk factor among the disease population divided by that in the healthy population. So the way we compute this is we take the quotient of the cases who were exposed to the risk factor to the cases who were unexposed to the risk factor. We take all of that divided by the controls who were exposed to the risk factor, which are divided by the controls who were unexposed to the risk factor. It's important to recognize that an odds ratio comes out of a case control study. So if one conducts a case control study, the only metric that can come out of that type of study is an odds ratio, not a relative risk, as we'll discuss soon. Vice versa, if one were to conduct a cohort study, one cannot compute an odds ratio from that study. One will be computing a relative risk. So for example, in a case control study, one could do the following type of experiment. 100 people with lung cancer were compared to 100 people without lung cancer. It was found that 90 individuals with lung cancer had smoked sometime in the past, while 25 of the controls had smoked. What is the odds ratio? We can plug these data into our equation for odds ratio. For example, we know that of the subjects who had lung cancer, 90 of them smoked and 10 did not. So the odds of smoking amongst those with lung cancer is 90 over 10, or 9. Of the controls, 25 of them smoked and 75 did not. So the odds of smoking amongst those without lung cancer is 25 over 75, or 0.33. So we now have two sets of odds, one for cases, one for controls. The odds ratio is simply the ratio of those two odds. So the odds ratio is 9 over 0.33 for an odds ratio of 27. In other words, those with lung cancer had 27 times greater odds of smoking in the past than those that didn't. Odds ratios of greater than 1 implies a higher likelihood of exposure to a particular toxin amongst the cases than the controls. In contrast to case control studies, cohort studies are prototypical prospective correlational studies. That is, they look forward in time. A cohort study identifies a group of people with a potential risk factor, the so-called cohort, and a group of people without that risk factor. It then follows them into the future to see if those with the risk factor contract the disease at a higher rate than those without the risk factor. Another way of thinking about these two types of studies is figuring out where your starting point is. If your starting point is the disease, you're talking about a case control study. If your starting point is the risk factor, you're talking about a cohort study. The output of a cohort study is the relative risk. The relative risk is calculated as the incidence of the disease amongst the population exposed to the risk factor divided by the incidence in the unexposed population. So relative risk factor then is RR is equal to the incidence in the exposed over the incidence in the unexposed. It's important to note that relative risk does not indicate the impact of risk increase or reduction on the population. Absolute risk is calculated as the difference in the incidence of the disease amongst the population exposed to the risk factor and the incidence in the unexposed population. So the AR, absolute risk, is the incidence in exposed minus the incidence in the unexposed. This is important because one may have a substantially high relative risk, but if the exposure is of very, very low frequency, there is very low impact to the population as a whole. The absolute risk, because it does not include a ratio, is much less sensitive to these low frequency values. The other reason an absolute risk is important is because you can use the absolute risk to compute either the number needed to treat or the number needed to harm. The number needed to treat for an efficacious therapy is equal to 1 over the absolute risk decrease in response to that therapy. The number needed to harm for a potentially harmful exposure is 1 over the absolute risk increase in response to that exposure. This gives the clinician a real number to get a sense of the impact of a particular therapy. So here's an example of a cohort study. 100 newborn children were studied for the risks of lead paint. 50 lived in homes with lead paint, and of these, 25 developed developmental delay within 5 years. 50 lived in lead-free homes, and of these, 5 developed developmental delay during the same time. What is the relative risk of developmental delay among children living in homes with lead paint? First of all, this study should be obvious to you as being a cohort study because we're beginning with the exposure. The exposure here is lead paint, and we are ending or looking for the outcome. The outcome here is developmental delay. Well, in order to compute the relative risk, we need to compute the incidence of developmental delay amongst these two groups. In the lead-exposed group, the incidence is 25 over 50, or 0.5. The incidence of developmental delay in the non-exposed group is 5 over 50, or 0.1. The relative risk then is 0.5 over 0.1. In other words, children living in homes with lead paint are 5 times more likely to have developmental delay than children living in lead-free homes. Practice question. A group of investigators studied the relationship between the 11q22 translocation and DiGeorgia syndrome. A study population was randomly selected from newborn infants. Blood samples were obtained for genotyping and chest x-rays were performed to evaluate the presence of thymus tissue. The group concluded that the 11q22 genotype is associated with DiGeorgia syndrome. Which of the following identifies the study design used by the investigators? The choices are A, case control, B, retrospective cohort study, C, cross-sectional study, D, prospective cohort study, or E, randomized controlled clinical trial. In this case, an exposure or risk factor was not identified. This study simply looked at the rates of particular genotypes and abnormalities assessed via chest x-ray in the population at a particular point in time. So this study would be most accurately described as a cross-sectional study because no attempt was made to correlate a risk factor with a disease outcome. Practice question. A cohort study to determine the relationship between elevated C-reactive protein levels and the development of acute coronary syndrome was performed. Data obtained after a 5-year follow-up revealed the following, and the data are presented in terms of elevations in CRP versus normal CRP and the development of the disease over time. According to the data, the relative risk of getting ACS in people with elevated CRP is 0.5%, 1%, 1.5%, 2%, or 5%. Well, remember, the relative risk is the incidence of the exposed versus the incidence of the unexposed. In this case, exposure refers to the elevation in CRP. So the incidence of the disease in those with elevated CRP would be 10, the number of people in that group who have high disease, over 20, the total number of people who were exposed, that is, had high CRP. The incidence in the normal CRP group would be 20, the number of people who have the disease and who have that positive test value, over 80, the number of people who have that positive test value total. So the ratio then would be, the relative risk, would be 0.5 over 0.25, and 0.5 over 2.5 is a relative risk of 2. Next practice question. A study was conducted to assess the association between smokeless tobacco and the development of lip cancer. Patients with lip cancer were asked about the use of smokeless tobacco, and people without lip cancer that were randomly selected from the same population as the patients were asked about their use of smokeless tobacco. The study showed that the use of smokeless tobacco has a significant association with lip cancer. Which of the following measures of association are the investigators of this study most likely to report? A, relative risk, B, median survival, C, odds ratio, D, relative rate, or E, positive predictive value. So the important fact that you need to answer this question is what type of study is being described. So here we are beginning with the disease process, that is lip cancer, and we're looking back for risk factors, that is the use of smokeless tobacco. In this type of study, we expect to get an odds ratio out of this study because this is a case control study. So the output we would expect would be odds ratio, and for that reason the correct answer is C. One needs to be aware of the various sources of bias in the studies that we've described. Retrospective studies, such as case control studies, are much more subject to recall bias than prospective studies. This is because individuals with the disease are more likely to recall risk factors than those without the disease. For example, people with lung cancer are more likely to remember being exposed to secondhand smoke than those without lung cancer. One solution to this is to use multiple sources whenever possible to corroborate collected data. For example, going to family members, friends, medical records, etc. Population studies of all types, whether they're retrospective or prospective, are subject to confounding bias. That is, the effect of one variable may distort the effect of another on the outcome. So for example, the USMLE Step 1 exam is designed to correlate preclinical knowledge with a score. However, this correlation may be confounded by the different ability of students to perform on standardized tests. One way around this is to perform multiple studies with different parameters. Clinical trials. Clinical trials are designed to study the efficacy of various interventions designed to prevent or treat disease. Here we're talking about something very different than the cohort or case control studies that were described earlier. In the cohort or case control studies, there is not an independent manipulation of one of the variables. We are simply observing the risk factors and what their impact is on a particular disease process. In a clinical trial, we manipulate the variables in order to see how they affect disease outcome. And we compare outcomes between a group that receives an intervention, the so-called treatment group, and a group that receives a placebo treatment, the so-called control group. Broadly speaking, 3 or 4 phases of clinical trials, depending on how you define the various phases. In phase 1, for a new compound, the safety of the compound or drug is tested on healthy individuals. These are conducted in small numbers of people to assess how well these compounds are tolerated and what types of side effects might be expected. In phase 2, the drug is tested on patients. That's the main difference between phase 1 and phase 2. Phase 1, healthy individuals are used. In phase 2, the target population, but a small number of patients in this population, are tested to determine the appropriate dose and to learn about the appropriate protocols for further administration of the compound. In phase 3, the efficacy of the drug is tested on a large group of patients in the target population. This phase of drug development helps us understand the side effect profiles during this phase. And this is the phase that determines whether or not a drug or compound will be approved for widespread marketing. Once a drug has been approved for marketing and for use in the general population, data are collected to assess the safety of this compound. This is called phase 4. And phase 4 continues for as long as the compound is out in the population. Clinical trials are subject to less bias than the previously described cohort and case control studies. However, there are still many forms of bias which may be incorporated into a clinical trial. For example, selection bias, measurement bias, investigator bias, and lead time bias. We'll describe these in the subsequent slides. Selection or sampling bias. The treatment and control populations are different and therefore not comparable. For example, the treatment group appears to do better based solely on the fact that they were less severely affected with the disease to begin with. This type of bias can be eliminated by randomization. This is commonly done in clinical trials work, and that is the patients who are put into the various groups are done so in a random way. Another form of selection bias is that the patients in a particular study may not be representative of the general population as a whole. Therefore, the results of the study may not be extrapolated to the entire population. For example, an internet health study selects only those patients with access to the internet, and therefore may not include the elderly or lower socioeconomic groups, and therefore the results of a study with patients selected in this manner may not be extrapolatable to the population as a whole. Measurement bias. This means that the outcome data are collected in such a way that bias in the outcome is put in a particular direction. So for example, individuals taking the placebo may report less relief of symptoms because they know that they are not taking the investigational drug. This type of bias can be eliminated by blinding. You blind the participant to which intervention they are receiving. You also blind the investigator. This is the most common way of conducting a clinical trial, and that is most trials are double-blind and randomized. As mentioned in the previous slide, the investigator may carry his or her own bias into a clinical trial. This means that the investigators may be aware of the status of the individuals they are evaluating. For example, an investigator is more likely to observe positive outcomes in the patient who is receiving the intervention than those receiving the placebo. Again, this can be eliminated by blinding the investigator as to which patients are receiving which treatment, And again, this is dealt with through a double-blinding mechanism, such that in most clinical trials, neither the patient nor the investigator know which subjects are getting which treatment, and there is a third party who controls the randomization codes. The gold standard for any clinical trial is to perform a randomized, double-blinded trial. This means that both the randomized patient and the administrator are blinded to the knowledge of who is getting the test and who is getting the placebo. This overcomes selection bias, measurement bias, as well as investigator bias. Again, does this mean that nobody knows who is getting what? No. As mentioned previously, a third party controls this information. Time bias. Let's say we report that individuals were diagnosed with a disease at age 20 and they live an average of 50 years longer, while those diagnosed at age 40 live an average of 30 years longer. Can we conclude that those diagnosed earlier have a longer survival time? The answer is no. We simply have a lead time bias. We're able to pick up the disease earlier, but that plays no role in the actual longevity or the outcome from this particular disease process. The only way to really assess whether or not early detection is efficacious in preventing a poor clinical outcome is by looking at the absolute age at which people develop the disease or the absolute age that they live to in order to compare adequately these two situations. Practice question. A new drug with in vitro activity against HIV is tested on a population of HIV-infected patients. Half the patients are chosen by lottery to receive the drug. The drug, which is tasteless, is administered in a cup of orange juice. The other patients receive pure orange juice. Neither the nurses, doctors, nor patients know which patient received the drug. At the end of the study period, the number of CD4 positive T cells is determined for all of the subjects. This is an example of A, a case control study, B, a cohort study, C, a double-blind randomized clinical trial, or D, a case report. The correct answer here is a double-blind randomized clinical trial because that's what the question is telling you. First of all, the subjects are randomized because it says that they are chosen by lottery to receive the drug or not to receive the drug. And it's double-blind because neither the nurses, doctors, nor the patients know who is getting the drug. The fact that the drug is tasteless helps ensure that nobody can figure out which subjects are getting the drug versus which subjects are getting the placebo. Investigators performed a case control study to investigate the possible association between cocaine use and death by homicide in an urban inner-city youth population. A preliminary analysis showed a strong correlation with an odds ratio of 5.0 and a 95% confidence interval of 4.6 to 5.4. Gang association was considered to be a potentially confounding bias. Which property of gang association is necessary for it to be considered a confounder? A, it shouldn't be related to death by homicide. B, it shouldn't be prevalent in the population of interest. C, it should be related to cocaine use. D, it should be observed in cocaine consumers only. Or E, it should not be controlled for in the data analysis. The definition of a confounder is a third factor or a third risk factor which is associated both with the risk factor under study and the outcome measure under study. So in order for gang association to be a confounder, it must be associated with both cocaine use and death by homicide. In this case, the only one of the 5 answers which contains at least one of those 2 is answer C, that it should be related to cocaine use. Question. A cohort study was performed to assess the correlation between public fitness center use and tinea capitis incidence. The study showed no association exists between center use and incidence. The investigators reported in their study that 25% of gym users and 38% of non-gym users were lost to follow-up by the end of the study. Which type of bias will most likely skew the results? Observer bias, ascertainment bias, confounding, selection bias, or recall bias? This happens to be another form of selection bias. Selection bias can occur in multiple different ways. The way that was described earlier was in the non-random selection of subjects to be put into various groups. The other way selection bias can occur is through asymmetrical attrition. That is, attrition more in some groups than in others. So in the end, we are no longer comparing comparable populations. So the correct answer here is D, because of the difference in the attrition rates between the gym users and the non-gym users. Practice question. A recent cohort study showed a strong correlation between getting a tattoo and liver cirrhosis. The researchers then divided the cohort into two different groups, those with hepatitis C and those without hepatitis C. Analysis after this division showed no correlation between tattoos and liver cirrhosis. Which of the following scenarios is described? A. Selection bias, B. Observation bias, C. Measurement bias, D. Recall bias, or E. Confounding. This actually is an example of confounding bias, and that is to say that initially there appeared to be a relationship between tattoo and liver cirrhosis. However, since both of these two are correlated with hepatitis C serves as a third potential variable that might be confounding this analysis. This was proven by separating the overall group into two different strata, one with hepatitis C and one without hepatitis C, and then ultimately this correlation then disappeared. And the reason is it was the hepatitis C that was driving the relationship or driving the formation of liver cirrhosis. So here we have a confounding variable as established or proven by stratification. Next question. A study was performed by two different groups of neuropathologists to determine a possible association between gender and Alzheimer's disease. Each group looked at 500 different brain biopsies. The first group was blinded to gender, but the second group was not. The second group reported that males had a higher incidence of findings consistent with the disease than did the first group. What type of bias may have been present in this study? Selection bias, observer bias, measurement bias, recall bias, or confounding. Well, the only difference between the two groups of pathologists is that one group was blinded to gender and one group was not, and two different conclusions were drawn. Therefore, the one difference between these two groups, and that is the status of the observer, is likely accounting for the difference in the results. Therefore, these results are being biased via observer bias. Practice question. A new screening test has been developed to detect Barrett's esophagus in GERD patients at pre-symptomatic levels using a previously unknown protein found in esophageal cells. Research shows that using this test can diagnose Barrett's esophagus 2 to 3 months earlier than by endoscopy. Researchers therefore concluded that this new test improves the risk of development of Barrett's esophagus. What is the potential problem with this conclusion? A. Respondent bias, B. Observer bias, C. Measurement bias, D. Lead time bias, or E. Confounding. Whenever you see a question that asks about the efficacy of a screening test, one has to be thinking about lead time bias, because simply detecting a disease earlier does not necessarily imply an improved outcome. That's the case here. We've shown that this test can diagnose Barrett's esophagus earlier, but there's no establishment or no proof here that this early knowledge of disease has any impact on outcome. Therefore, the correct answer here is lead time bias. That concludes our discussion of clinical research methodologies.